Okay, thank you for attending the first CGD Symposium at an IDF National Conference. We're looking forward to an amazing couple days. My name is Kara Moran. I am the Communications Manager at IDF. I manage livingwithcgd.org, the new website dedicated to CGD. We're so happy with the turnout. We apologize for the close quarters and the long line for lunch. We had so many people that wanted to attend, so we had a little bit of close quarters, but the good news is that we're reaching more people, so we're just really happy that you're all here. To start us off, I'd like to introduce Mary Hurley. She's a member of the IDF Board of Trustees and founder of the CGD Association. Mary?
I just want to welcome every one of you here. It's just some of you I've known for maybe 25 years. Kind of shows my age, but I feel like we're a family here. I've known so many of you, and I've also known the doctors here that are a blessing to all of us, you know, that have this disease. Like I said, my name is Mary Hurley, and I am on the board of the IDF and the president and founder of the CGD Association. We found our association in 1982. Marcia Boyle found hers in 1980, and we've been working together with our common goals of keeping CGD patients healthy and looking for a cure for everyone so we won't have these meetings. And I want to thank Horizon for sponsoring this wonderful meeting. Without them, it would not be possible. And I'd like to introduce you to Brian Andersen. He's Vice President of the Orphan Business Unit at the Horizon Pharmaceutical. Thank you.
Great. Thank you, Mary. It's with great pleasure that we're here today to support this initiative. We talked about this the last national meeting. I think there was maybe 20, we're talking maybe 20 CGD families there. Last year at the Atlanta retreat, we had another special session where I think there was maybe 40 patients and families there. And so now I think we're up to 78. So we're going to try to double it next year at the next retreat, right? Mm-hmm. So it's great to see everyone here. I think we have a great afternoon planned here with some great physicians that I think many of you know. And we've been involved in this in CGD for a couple years, and really these ideas working with the IDF have come out of patients saying that they feel alone and that they don't have people to talk to. And we, in a couple meetings ago, we were actually in a room with two people from Minnesota, Minneapolis, Minnesota, that see the same doctor that didn't know each other. And I said, this is not acceptable. So that's what we're trying to do here today is get everyone together. I think you guys face a lot of the same challenges. Horizon's here to support you guys, as well as obviously the physicians that are here today. So I'd love to turn it back over to Kara, and we're really excited to be a part of this meeting. Thank you.
Thank you, Brian. As I mentioned earlier, in January, IDF launched a website dedicated to the CGD community, livingwithcgd.org. I manage the site, and so far we've received a great response. Livingwithcgd.org provides comprehensive medical and life management information from CGD experts. Individuals and family members can share their stories through inspiring videos and blog posts. In fact, you can share your story here at the conference, either by recording a video or being interviewed for a blog post. We are fortunate to have a wonderful consultant who is working on behalf of IDF to help us do this, Felicia Morton. Felicia? Felicia brings tremendous marketing and public relations experience to this project, helping us develop all the content for the site. But most importantly, Felicia brings the perspective of a mom.
Thank you. I really wanted to let you know how grateful I am to be here and to see all of you. I had just posted a story on Living with CGD about how far we've come since Sebastian was first diagnosed at 6 months. Right after that, he had turned 1, and we went to Baltimore, and it was our first experience with IDF, and it was very daunting at first, but as soon as we walked in, we immediately felt like we were with family, and Sebastian was just learning how to walk at that point, and we were just learning about CGD, and since then we've come so far thanks to the support of the Immunodeficiency Foundation and Horizon. We have a tremendous platform to meet and to grow. Both Sebastian has grown from, learning how to walk to now he's scooting down the hall or a sidewalk on his scooter. So we are just so thankful for this opportunity to get together. I'm so honored to be here. And thanks again to all of you. I know many of you through the blog, through writing about your stories. Thank you so much for sharing your stories. And thank you so much for being here. I look forward to seeing you all during the course of this event.
Thank you so much, Felicia. Please make sure you meet Felicia either today or tomorrow, okay? And try to arrange a time to share your story with her or record a video in the Real Stories studio. Okay, when you sat down on today we have a questionnaire that Dr. Sullivan mentioned. If you could just complete that questionnaire either today or tomorrow, and you can hand it to me, or I think there's a box in the back. Just a few housekeeping things. Also, we will be receiving questions for the presenters, but we also have cards for you to write your questions down. So after the presenters do their presentation, they will answer those questions, so that as to keep things moving. But there'll also be a Q&A session at the end. So you can wait till the Q&A session, or you can write it down on the card, which are available in the back, and I can make them available to you. Let's see, any other things? That's it for right now. I'm going to go ahead and turn it over to Dr. Sergio Rosenzweig of the National Institutes of Health to start us off.
Thank you very much, Guys, thank you very much for being here. We'll try to keep it as informal as possible, so interrupt as many times as you want. If I like your question, I'm going to answer. If not, I'm going to say no. So you can try. I'm going to decide. Do we have a pointer? Yeah, that's the best pointer we can have. So thank you very much for coming here. So when we thought about this session, we thought about thinking of going from easy to more complex. I'm the easy guy, so I'm going to try to go for why does CGD make patients sick, and how does CGD present? So please interrupt me as many times as you want. So I told you I was going to go simple. We all have an expertise here. So you have the expertise of being a patient. You have the expertise of being doctors. And you teach us about primary immunodeficiencies. So this is a definition that I like about PIDs, because it actually kind of covers all the aspects about PIDs. So when we are talking about primary immunodeficiencies, so we are talking about disorders that are a diverse group of illnesses that, as a result of one or more abnormalities of the immune system, increase susceptibility to infection. The primary immunodeficiencies are genetic disorders with characteristic inheritance patterns. So some of you might think that this is a new idea, that perhaps Marshall Ball came up with that idea in 1982, but actually it's not. This is a pretty old concept. Actually, the first guy that thought that people were more susceptible to infection, it was Abu Bakr Mohammed bin Zakaria. Try to repeat with me. Abu Bakr Mohammed bin Zakaria. Okay, for friends, Razi or Rasen. This guy, 1,000 years ago, he said, you know what? Not everybody going to get infected with what they want. They're going to get infected with what they can. Depending, or in his case, so he used a very basic approach. He said, if you are chubby, are you a light skin? You are more susceptible to infections than you are skinny and dark skin. And actually, this is a concept 1,000 years ago. But I know somebody in the room, but he thinks that he was the one that thought about that first. Do you recognize him? Actually, at some point, he even grew a beard to look like Razi. So I know that he did it for that reason. So, but now, moving forward. So, primary immunodeficiencies. We know that people believe that they are very common diseases. Some others believe that they are not that common. The incidence is not that clear. Some people claim that they're 1 every 1,200. Some others claim there's 1 every 20,000. Probably it's between the middle of those numbers. more males are affected than females. And then one of the ways that we classify the PIDs is based on which compartment of the immune system is affected. So here you have the humoral compartment, that they're the B cells, or they're bioproducts, that they're the immunoglobulins or the antibodies, and this is the most common one. Combined, when you have T and B immune deficiencies, all together they're kind of 80% of the PIDs. And then we have all the others. And here are the ones that we are going to be talking about. We're going to be talking about CGD. They say phagocyte cell disorder. When we are talking about PID, in general, we are talking that most of them, they share kind of the same manifestations. And when somebody gets a PID, usually gets a triad. So it's not just susceptibility to infections, that kind of is the hallmark of PIDs. They also have autoimmune or inflammatory or autoinflammatory diseases. And some of them, they have neoplasias. And it makes some sense. Whenever our immune system doesn't work, we don't know how to fight the outside, so we get a lot of infections. And sometimes our immune system also gets confused, so start to attack ourselves. That's the autoimmunity. And then the immune system has another function. It's called the immune surveillance of cancer. So some patients with T cell defects and other defects, they do have susceptibility to cancer. So PIDs is usually a very complex syndrome because you can get the three of them. Not all PIDs get all of them, and we'll be talking about which are the ones that are more prevalent in CGD. So then symptoms, they start early in life for most of them because, as we said, they're genetic disorders. So we are born with them, and many of them start pretty early. Some other start later. So 10 to 15 to 20% of PIDs, now we know that they're going to start later. You carry them since you are born, but it's going to take 20, 30, 40 years before it manifests. So infections is kind of the hallmark, as we discussed, about PIDs. And again, as Abu Bakr Mohammed bin Zakaria said, or Steve, so not everybody gets the infections that they want, they gain the infections that they can. And that depends on which part of the immune system is the one that's not working fine. Each compartment of the immune system help us to neutralize different type of organisms. For example, T cells, they do everything. They help us to control bacteria, virus, parasitic, fungal, and mycobacterial infections. But here, NK cells, they're only good in order to control viral infections. So that it means is depending the type of infections that you get, which going to be the compartment of the immune system that we will suspect is affected and is giving you some susceptibility to infections. As we said, PIDs are genetic disorders. And now going to CGD, this is what CGD is. CGD is a genetic disorder. Here you have a list of 1, 2, 3, 4, 5 genes mapping to 5 different chromosomes, coding for 5 different proteins that they give the same syndrome. CGD is a disease with genetic heterogeneity. What it means, you have 1, 2, 3, 4, 5 genes and one disease. Most of the times they are indistinguishable. So 5 genes, one disease, this is what we call genetic heterogeneity. Also, here you can see that 4 of them, they have an AR. This is not because I'm from Argentina. AR means something different. It means, oh, thank you. AR means autosomal recessive. What it means, we are made by 2 halves. Half information from mom, half information from dad. Whenever people have CYBA, NCF1, 2, or 4, it means that both copies, the maternal allele and the paternal allele, are both mutated, and both of them carry a disease that the patient manifests. So this is the case with the autosomal recessive forms of CGD. Here is not extra large, this is X-linked, and this is the most common form of CGD, and this is just mapped to the X chromosome. Here, males, we're at some selective disadvantage. We only have just one X chromosome. If that chromosome is affected, we don't have any backup copy. Females, they have 2 copies, so they have one or another. So that's why this one is manifest in males. Here is the proportion of CGD patients that they do carry the different type of genetic forms. You can see that some of them are more prevalent than others. So X-linked CGD is highly prevalent in Western countries. If I go to talk to Saudi Arabia or to Iran, so they would say, you are wrong, because here the most common forms are the autosomal recessive, and it's because the high rate of consanguinity. So I told you, you need 2 copies, and if those 2 copies are from relatives, there's a lot of consanguinity in the Middle East. So there, the distribution of CGD is completely different than the ones that we have here. If you go to Korea, they will have a lot of these ones. So yes, Western countries, we follow this rule, but different countries, they have different genetic backgrounds, and they can have a different kind of distribution. So 5 genes, 5 different chromosomes, 5 different proteins. So why these 5 genes that they map to completely different chromosomes, 1, 7, 16, 22X, they are just built or make that you have a single disease. And the point is that all those genes map to different proteins, GP91, P22, P40, P47, P67, that all together they make the NADPH oxidase system. So that's why 5 different genes that look not to be related at all, they make together this complex that is the one that is affected in patients with CGD. So now let's go geographically where that happens. I already showed you here a membrane, here's the cytosol, but where that does happen. So that happens inside the neutrophils or the monocytes. So those are the cells that they carry these proteins. There's in other cells too. B cells also have it, T cells also have them, but actually the main cells, that they're the ones that are responsible to carry the NADPH oxidase, and what it does are phagocyte cells, neutrophils and monocytes. And here you can see, we have here the nucleus, and when here the primary granules, that they have enzymes that help us to clear infections, and here we have the secondary granules, that they carry the cytochrome B558 that carry 2 of the proteins from the NADPH oxidase system. So how does it work physiologically, or whenever these cells get activated? So follow me here. So this is a phagocyte, and here you have something, a phagosome, that engulfs bacteria or fungi. What happens when those cells get activated? So here you have the whole system, and the whole system, what it does, it just donates 2 electrons to oxygen, and then makes a compound that's called superoxide. Superoxide is good. It might kill cells, but it's not very stable. So we have to go very fast to make something more stable. So through spontaneously or through superoxide dismutase, we generate hydrogen peroxide. Again, hydrogen peroxide is good, but it's not the strongest way of killing microorganisms. So we can degrade that, or we can produce bleach. And then bleach is the one, the same bleach that you use to cleanse the toilet is the one that we produce. And actually, this bleach, that is exactly the same that Clorox produce, without paying any royalties to nature, so is the one that we generate in our white blood cells in order to kill fungi and bacteria. So this is how it works, and this is how genetically happens CGD, and this is how biologically happens. So going back, just trying to summarize whatever we have discussed so far, we know that the NADPH oxidase is mainly expressed in phagocyte cells. So now you can imagine which are the type of infections that patients with CGD have. It's not by chance that they have bacterial and fungal infections, and some of them have mycobacterial. They do have those diseases, not because they attended my talk, that I like that you are here, because these are the cells that they are affected, and this is the activity that these cells can produce. They are not good at killing viral infections. It's not that patients with CGD cannot get them. They're kind of standard in terms of their susceptibility to viral infections, but they are susceptible or highly susceptible to certain type of bacterial, fungal, and mycobacterial infections. But I told you, whenever you have a patient that do have a PID, it's not the nicest combo possible. It's not just the susceptibility to infections, it's the autoimmunity or immune dysregulation plus the neoplasia. In patients with CGD, neoplasia is not higher than in the general population. But yes, they do have a lot of autoinflammation or autoimmunity. The mechanisms why they have autoinflammation they're not that clear, or they're not as clear as the ones that they have infections. But we do know that they produce abnormal reactive oxygen species, so they increase the production of cytokines. Cytokines are kind of the messengers between immune cells. So in the endocrine system, we call them hormones. In the immune system, we call them cytokines. So they increase, bringing more immunological cells. Those cells, they don't usually die as they should die, and they start producing a lot of cytokines that they try to recruit more cells, and they produce granuloma. So we don't know exactly, that's why it's full of question marks, why that happens. But we do know that patients with CGD is not that they have just increased susceptibility to infections, they have increased granuloma formations, autoimmunity, and immune dysregulation. And we'll be talking about that later during our session. So actually, CGD is kind of a yin-yang thing. So you have here a patient with CGD that have a lot of infections, and here we describe the type of infections, and here we describe which are the manifestations. I know you cannot read. I cannot read even from here. I apologize for that, but I couldn't get a better picture. So, but the thing I can read for you, no, not even from here. So, but you know, patients with CGD, they get both. They will get infections, and they will get immune dysregulation. And always, whenever we have one patient and they have a fever, we have to think about both of them. It's not always antibiotics. Sometimes it's going to be antibiotics, and sometimes it's going to be steroids, and sometimes going to be both of them, because we know that you have this problem, and we have to combine the two approaches. So we know why our patients, they do have infections, and I will show you how those infections present in our patients. So that's the other one. We know how they have autoimmunity. And here is kind of a description of which type of infections our patients have. So and this is a series from the US, so it really represents whatever is happening among us here. So most of our patients, they do have infection. I would say that 99.9% of our patients, they're just very few, but we know them, that they have CGD and they have no or very little number of infections. But patients with CGD, they will get a lot of infections. And the big three, the most common presentation, the most common infections, are going to be pneumonia, abscesses, and adenitis. Yes, they have osteomyelitis, bacteremia, and fungemia. That means that the bacteria travel through the blood, or fungi travel through the blood. Cellulitis, there's inflammation or infection of the skin, meningitis, brain, and other infections. But these are the big three. So most of our patients are going to get several of those infections, especially if we cannot prevent them. And this is how they look. So they can look as severe like that. This is a patient that aspirated fungi because he was mulching. Mulching is not a good thing for CGD patients. So I don't know who likes mulching, so give it to somebody else. Please don't mulch, because that could happen. But that could be seen in an X-ray. But look at this. This is another CGD patient that presented almost without clinical symptoms, because some of you are going to present just to a control, and we said, okay, we need to do a CT scan. I said, why a CT scan? I feel great. Because we know that X-rays, they're not always sensitive enough. And there are small things that will only show by CT scan. There are going to be another things that will make us suspect that you may be infected, like sedimentation rate or CRP, that usually elevated, even you feel well. But one of the things that happens with patients with CGD is that they don't always feel bad whenever they have an infection. Oh, sorry, it wasn't me. So here's the thing. So CT scan will do many, because we know that there are things we will not see in X-rays. So then I told you that some patients with CGD, they can present also with mycobacterial infections, and this was a patient with a mycobacterial infection. But here we have an advantage. The rest of the world, they use a vaccine that's called BCG, that we don't use here in the US. So those patients, when they are born, we put under their skin 3.2 million of mycobacteria. 3.2 million, a lot of them. So what happened to those patients? What happened to my patient? Look here. Here you see something white. This is calcification, because this patient was vaccinated and then developed BCGitis. So we do know, and we have here the advantage not to test our patient with the BCG vaccine, because this is what can happen. So because our patients, our CGD patients outside the US, they get BCG vaccine, we have a different kind of clinical manifestations. So for example, I told you do not mulch, but you didn't hear me tell you do not drink mate, because mate has as much aspergillus as mulch. So if anybody's you from South America, you know what I'm talking about. Somebody from South America? Okay, I'm the only one mate drinker. So, okay. Oh, there's someone. Do you drink mate? Okay, don't drink anymore. Oh, yeah, if you're a CGD patient, you can do it. But you know, mate has a lot of aspergillus. It's kind of more aspergillus rather than mate.
And it tastes like it.
No, it tastes like shit. Sorry, it tastes horrible. But I like it. So, abscesses. I know that Dr. Heller is going to be talking about the GI tract. I'm going to talk about an organ, a solid organ, the GI tract. So sometimes, infections are not in the lung, they're in the liver. And you can see here this small shadow. So this is an abscess in the liver. So this is pretty common. Patients with CGD, up to 1/3, will have at some point of their life a liver abscess. And actually, we have to do a different type of approach that Dr. Holland is going to talk later, because those are solid. They look like baseball balls. They're not empty. So usually when patients get liver abscess, we drain them. When we try to drain that, nothing comes up because it's like glue. So we have to take different approaches that he will talk about later. So then adenitis. That's the other thing I was telling about, the big three, which are the most common infections. How does CGD present? So here you have a typical adenitis, and here you have 3 different interesting things about this patient. So what do you think is interesting about this patient? He's female. What do you think is interesting?
I don't know.
He's a female.
Oh, you want me to-
Okay.
Female?
No, wrong. No, yeah. She's a female. She's a female, but she has the X-linked form because she did something wrong with her cells. She inactivated all the good ones, and she got active all the ones that they are sick. So she behaves as a male in terms of X chromosome inactivation. So we can see females that they have the X-linked form of CGD. And here, you can guess that there's a scar because she behaved as a male with X-linked form. And then she also had manifestations that are typical from female carriers, discoid lupus. So here we have 3 things that they are not the most common things. Females carrying the X-linked form, behaving as CGD, and also having the manifestation that we typically see just in the carriers. So this is kind of a weird situation, but we have to be used to that too. Other things that we use in order to think about CGD. So we do profiling. So whenever we hear about particular microorganism, we know that we have to think about CGD. So staph, okay, everybody can have a staph infection, but nocardia, Serratia marcescens, Chromobacterium violations, Granulobacter betulensis, so they have a positive correlation value of kind of 100%. If you hear somebody that has Granulobacter betulensis described at the NIH by Dr. Holland in CGD patients, guess which patients get this microorganism? It's just CGD. If you think about Chromobacterium violation, 99% of the patients that get microorganism, they have CGD. Similar things happen with Serratia marcescens. Nocardia, there are patients that they can be no CGD and still get it. But whenever we hear that patients get these kind of infections, we know that it's a highly chance that those patients have CGD. Burkholderia cepacia, patient with cystic fibrosis have it, but it's very prevalent in patients with CGD. Aspergillus, patients with neutropenia, hyper IgG, but also CGD. So those are the ones that we profile. Whenever we get a consult and somebody tells us, we have a patient that has Aspergillus, think about CGD, because this is something that you have to do. Mycobacteria, they're different diseases, but we do profiling. And we do profiling not just with the microorganisms, also we do profiling with the localization of the infections. Anybody can have a pneumonia, but osteomyelitis, we know that almost 25% of patients with CGD will have osteomyelitis. So if you have osteomyelitis due to staph or due to Aspergillus or Serratia, we know that it's very likely that you have CGD. So we use profiling. Yeah, that's not right, but we do it because it helps us to diagnose these patients. Lymph nodes that they have adenitis, also another hallmark of patients with CGD. So we say that our patients not only have infections, they have autoinflammation or immune dysregulation, not that clearly understood as the infectious disease predisposition factors. But here is how they present. So here we gave contrast to the patient, but it didn't go through the stomach. Why? Because it had an obstruction here. This hyperinflammation obstructed the GI tract and doesn't allow the food to go through. So this is not infectious, this is inflammation. This is granuloma formation because of immune dysregulation. It can happen in the GI tract, and Dr. Heller is going to talk about that after me, but also it could happen in the urinary tract. That inflammation can happen in the solid viscera, but also in the hollow viscera. And here you have a patient that had a fistula, had a Crohn-like disease, but also have a fistula because of the inflammation of the bladder. So again, CGD comes in two flavors, and usually they're mixed together: susceptibility to infections, immune dysregulation, and granuloma formation. So one more thing that we see among patients with CGD, they usually don't heal well. We don't know exactly why, but whenever they have surgery, they take a lot of time in order to close the wounds. We know what to do. We know that there's some medication that might help them to close faster, but this is something that's also characteristic, and perhaps some of you have experienced it, that whenever you have surgery, so wounds do not heal fast. So now, just to conclude, let me summarize what we discussed. I was asked to talk about two things. Why does CGD make you sick, and how does CGD present? And I guess that we came up with a couple of answers. So why? Because CGD is a genetically heterogeneous disease caused by defects in NADPH oxidase. So it's a genetic disorder that affects the NADPH oxidase, and this, down the way, affects the respiratory burst of the generation of reactive oxygen species. How it's characterized, how it does present, it presents usually with recurrent infections that they are bacterial and fungal. Why? Because NADPH oxidase is expressed in phagocytes, and those are neutrophils and monocytes, and those cells help us to control bacteria and fungi. That's why CGD have these kind of infections. It's not just because by chance. It's because of their genetic trait, it's because of the biology, it's because of the pathophysiology. And also, these patients have abnormal granuloma formation and immune dysregulation. So, I think that I answered those questions. I think so. So I want just to thank you, our patients, our families, their families, our students and colleagues, because actually it's a constant challenge. So you are teaching us and you are challenging us to learn more, try to give back to the community. So thank you very much.
You know, so I didn't get Sergio highlighted into my slides, but I'll see what I can do. So my job is to talk to you a little bit about medical management of chronic granulomatous disease. And that's actually very important because, you know, it doesn't matter whether you think you're going to have bone marrow transplantation or your child is going to, or you're going to have gene therapy, or you're waiting for the next coming. It doesn't matter what you're waiting for, because everything that happens between now and then is medical management. And so no matter what you think the future holds for you, somehow you got to get there. And so what we're going to talk about is everything that happens while you're waiting for whatever it is you're waiting for. And I don't know about the lottery, but what I'm waiting for is, you know, dinner tonight. So I got to remind you how far we've come, because, you know, it's very important to have perspective. And this condition, what we now call chronic granulomatous disease, was first described only 61 years ago. Now, people like Sergio were there at the first description. You know, those of us that are a little bit younger, you know, maybe not. But this disease was first described, it was found by accident. And they were looking for something different, and they didn't really know what they had. They said, this is a funny disease with severe, recurrent, and chronic infection. That's all they knew. And it was 5 years later, in 1959, that the group led by Dr. Good in Minneapolis referred to this as fatal granulomatous disease of childhood. Now, that's a bad name. That's a petrifying name. And in 1959, think about it. Think about what antibiotics there were. There were no drugs to treat fungi. It was a fatal disease in 1959. But listen, damn it, this isn't 59 no more. And so things are changing, and we're moving on. And I got to tell you that story because you got to keep in mind that we are moving forward, we are going forward, and we are making things better. So that was 1959 when they said, boy, oh boy, this is bad. A few years later, still the group led by Dr. Good in Minnesota, but also Dr. Cui, then also in Minnesota, recognized something very important. And this is really important for everybody to appreciate, especially for doctors, but you guys already know it. And that is that patients with chronic granulomatous disease have some problems, but not universal problems. So look here. They took bacteria, they mixed them in with cells, and they said, can those cells kill bacteria? A very, very simple question. Well, here's the deal. If you're a normal neutrophil, you gobble up bacteria, and the number in the thing go down. They go down, down, down. That's 3 normals, all able to reduce the number of bacteria in a tube. Patients with CGD can't reduce it, but you see that the bacteria aren't growing. That would be up like that. They're staying stable. That is, they're able to do something, just not quite enough. But that's the difference between making it through most days and making it through every day. And then, now just 30 years ago, the first time people were able to go back and say, oh wow, here's a gene, and now we know exactly where it is. 30 years ago, people realized that the gene for chronic granulomatous disease, the X-linked form, was here on the X chromosome on what we call the short arm of the X chromosome. Long, short, and that's where the X-linked CGD gene is. So the very first time somebody figured out exactly where a gene was, it was chronic granulomatous disease. So this disease is important not just for us who are involved with it directly, but it's been critically important in pushing science forward. And then I got to remind you how things have changed. So I told you that in the 1950s, they called this fatal granulomatous disease of childhood. And the first patient who showed up at the NIH, and this is only data from the NIH, the first patient came in 1972. And he died at about age 8. And here what we're looking at is the ages at which people died between 1972 and 2012. And what I need you to notice from this is that that curve is going up. This doesn't say how old people survive. People survive now pretty old as they feel like getting for the most part. But the age at which they die has been increasing. That means that our worst outcomes are now much different than they were back here. But look, we're all here because this is a serious disease. There's no making fun of this. There's no making out like, this was a problem in the past. It's not a problem in the past. CGD is still a big problem. And that's why we're all still so motivated. So now I got to just remind you, what are the 4 pillars of CGD management? So if we had 3 pillars, that would be a stool, but that's the topic for Dr. Heller. Okay, so we're talking about 4 pillars here, and it's things against bacteria, things against fungi, interferon, and then common sense, which I think all of us know is honestly the hardest thing to come by. So now I got to say at the beginning, we're here, there's a conference all about zebras, right? So everybody says, well, my zebra is special, right? I know how it is. I know many of you as parents, well, I know about all those other kids, but my zebra, that's a special zebra. He doesn't get that. He would never do that. But, zebras are a little different. Some of them look one way, some look the other. We got to talk about them as a whole, because if we don't talk as a group, we can't talk. But we all realize that there are differences, and there are differences. I don't disagree with any of that. All I can say to you as a doctor is I can't always tell what makes those differences. So let's just talk about bacterial infections for just a minute. So let me just acknowledge here at the beginning the person who has really been driving a lot of the critical information in chronic granulomatous disease over the last 15 years has been Betty Marciano. And she has 2 major distinctions. Number 1, she's an outstanding investigator and clinician. Number 2, she has tolerated even more from Sergio Rosenzweig than I have because she's married to him. But she has done a fantastic job putting all this stuff together. And let me just show you. So I'll remind you, as Sergio pointed out, there are these 5 genes that all come together, 5 proteins that make one complex that makes eventually bleach. And mutations in any one of them cause chronic granulomatous disease because you can't make the superoxide, which then helps make the bleach. And that, for reasons that are still a little complicated, makes infections possible inside of cells. And as Sergio pointed out, there are differences in the types of chronic granulomatous disease. There are 5 genes, but this is one of those things where it gets complicated. You know, it's one disease that we talk about, chronic granulomatous disease, even though we recognize that there are differences in how you get there. But it's sort of like, you know, whether you came here from California or from New York, or even those who tried to come from Washington, you're still in New Orleans. And so we have to talk about that. Now, there are only a few infections that are really common in chronic granulomatous disease. So just these top 5 are really common in chronic granulomatous disease: staph, serratia, Burkholderia, nocardia, aspergillus. You don't need to know these, but I know you've heard these. Every one of you who has had a patient in the hospital has heard somebody use these terms. Either use them too fast or use them and say, I don't know what it is, but it's not X or Y or Z. But these are the things they're always talking about. And if you're from someplace else, typically things like salmonella or BCG, that vaccine that they give in still some countries, those might be possible. And then there are these funny bacteria that, not only can your doctor not usually pronounce, but really are very unusual, even in chronic granulomatous disease. These things like Chromobacterium violatium or Francisella filomerangia or Granulobacter bethesdensis. These are funny organisms, but it's important that you know about them because sooner or later you have to be able to remind your doctor. And I mean this very honestly. You all know this. Anybody here ever gotten stuck in an emergency room as a parent or a child or a patient? And how many times do you say to the doctor, well, actually, this is a problem with chronic granulomatous disease? And, like, what do they say? Like, what? See, I've had one patient who said the doctor said, no, what are you talking about? There's no such thing as that. And as the patient's walking out, she sees the doctor going through the textbook saying, like, chronic granulomatous. You got to know this. You got to know it better than them because they don't know it. That doesn't make them stupid. It just makes them uneducated. You can't afford to be uneducated. So here's the deal. So these are the 4 main types of CGD. This is the X-linked form. And what we're looking at here in red, everybody who had more than 5 infections. Now, this is only people followed at the NIH. So it might be different other places. There are people in Oz who never get infections with CGD. But we don't live in Oz. We live at the NIH. And I think we're pretty careful about it. So the X-linked form, most people get a lot of infections. And that's true with some of these other forms as well. Even this, the most common, what's called P47, the most common autosomal recessive form, the one that occurs in girls and boys equally. But you can see that there are a lot of patients who only get a few infections, and then there are a few who have only had 1 infection, that is, they get picked up early in life and then got started on treatment, and for whatever reason that I can't really explain to you, they seem to do better. And then there are very few patients, typically with the X-linked form, who got picked up for a variety of different reasons, who never had an infection. Maybe because they had a mild form of CGD in the first place, maybe because they got started on prophylaxis early, but very, very small numbers. So the take-home message here is that most people with chronic granulomatous disease are going to get infections, and most people are going to have more than 1. But the infections are different, and they differ by region and by type. So this is a very busy slide, and I'm only going to remind you that some things almost only occur in the lung. So Aspergillus, the fungus, almost only occurs in the lung. Burkholderia, a bacteria, almost only occurs in the lung. Staphylococcus, on the other hand, only occurs in the skin or the lymph node or the liver. It almost never occurs in the lung. Weird. Actually, completely not what anybody expects and not what anybody appreciates. But you don't need to know that distribution. Your doctors need to know that distribution. But you need to keep in mind that when something swells up here, it may not be the same as when something's in here or someplace else. So about a third of CGD patients get liver abscesses, about a third get fungal infections, but we cannot do a very good job of telling you who's going to be whom. So that's the background. So how do we prevent all that? Bactrim or Septra is a very, very good drug for doing this. And we recommend that people take it twice a day, either a single strength or a double strength, depending on how big you are and how able you are to swallow pills. And having taken these pills myself, they are not trivial, right? I mean, you have to have a small horse's throat in order to be able to do it. And there are liquids available, and you can take single strengths and so on. When you do this, the studies show that when you take this, the infections go from 1 time per year without antibiotics to 1 every 3.5 years. Now that's on the aggregate. That doesn't mean that's going to be true for every individual. There's some people who might go 10 years. There's some people who might not go 1 year. So we're talking on average. And everybody's zebra is different. I can't tell you always how to do it. What happens when you've got an allergy to this? Well, so nobody knows. And so anybody can do what they want. But we use often trimethoprim alone. Remember, it's trimethoprim sulfa. This is almost always what causes allergies. We use this one alone. It seems to be okay, but you could use almost any other drug you want that you and your doctor work out together. Now, Sergio talked about liver abscesses, and I need to tell you something very special here about how that has changed over the last few years. So this is this liver abscess here, and you see that spot, and here is the abscess that was taken out of it at surgery. And up until a few years ago, we felt very strongly you always have to do surgery to get these out because they just don't get better. They're too thick. They're too yucky. You gotta go in and take it out. And this is what they look like when they come out. And you can see it's still a big solid ball with little bits of pus inside it. It's not a beignet. Don't think that. So the problem is with these things, so they're almost always due to Staph aureus. And they're complicated. Sometimes people have pain and fever, but sometimes not. And, usually the blood work, the sed rate, or the C-reactive protein are very high. So in the old days, we would do surgery or drainage, and all the time with IV antibiotics. And then, as is often the case, we had a problem. And the problem was this young man who came in with this abscess. And I talked to the surgeon, and I said, boy, I'd really like you to operate on his abscesses. And there was this one here, and you see there's this one here. And he said, yeah, fine. And he did the operation. And when we looked a week later, I said, well, thank you for taking out that, but what about that and that? He said, oh, yeah, I tried. I said, well, I tried? I tried's not really a terribly good answer here. He said, yeah, but it was hard. It was hard. And it was hard because this one is right here on top of a vein. And he said, sure, I can go in there. But if I go in there and I get into that vein, that's the major vein in the body, that will kill him. So I said, well, thank you very much for your help. And then he had a trip, so he left. And so we were stuck trying to decide what to do. And so we went back, and we went old school, and we went back to papers by Dr. Steen that suggested that steroids might actually be helpful here. And we were quite scared because here we had an infection right near a big vein, and we really didn't know what to do. So we read this paper, and we said, okay, let's try it. Let's try and regulate that inflammation and knock it down and see if we can't make the infection better. And sure enough, here he was before, and then about a month later, after steroids and antibiotics, it was all gone. And, one time you say, well, anybody can make something happen once. It's making it happen twice that really counts. And in fact, we started doing this on other patients who had so much abscess formation that we couldn't take it out. It's not that surgery's not good. It works great. But it's a big operation. And we realized that some of these patients that had too much infection that we couldn't do by surgery, we could do it with steroids. And in fact, we've now done 12 patients this way. And we've stopped doing big-time liver surgery for these abscesses. Not because the surgery's not good, but because this is a way to do it that's even easier. And so what we do is we make sure that it's staph. I only know that this works for that one infection. If there's any liquid there, we go in and drain it. That is with just a little tube. And then we give steroids and antibiotics. The steroids have to go on for a few weeks. Don't try and skimp on that. It's really important. And you can't do it without antibiotics. You can't just say, well, I think I'll take, a Bacterial once a day and some steroids and be done. It doesn't work like that. You need the IV antibiotics. You need the steroids. Together, they seem to do a very good job. And it turns out that for other aspects of CGD where there's a lot of inflammation, we can do the same sort of antibiotics and steroids together very effectively. And the same sort of thing happens with nocardia. So here was a guy who had bad pneumonia. We could not get it ready. We were ready to call the surgeons and take his lung out. And then for a variety of reasons, we thought maybe we ought to try the same approach. So here, this is before steroids, after. This guy, you see his whole lung here was involved, and after steroids, he was back to normal. Both these young men got away without having it done. It cannot be done as a simple outpatient procedure. You can't just go in and have somebody say, oh yeah, that's fine. Just go ahead, take these things, call me in the morning. It takes a lot of intensive work with your doctor, but it can be done. Now let's just talk for a few minutes about fungal infections, because these are a big deal. There's no question fungi are still the infections that are most often fatal in chronic granulomatous disease. They're still a big ticket item. So the drug that everybody really, I think, should be on is itraconazole, not fluconazole. Fluconazole is very good for yeast, which is not a problem in chronic granulomatous disease. You don't have a yeast problem, you don't have a candida problem, you don't have a thrush problem. Fungi are treated by itraconazole or some of the other ones. So here, the treatment we think is 100 milligrams or 200 milligrams once a day, depends on how big you are. And we know from very big studies done at the NIH and other places, it really reduces the amount of fungal infections you get. It really, really does work. But that doesn't mean, just because it reduces the rate doesn't mean it stops it. It doesn't. People still get fungal infections. You know that and I know that. So what do you do when that happens? Okay, I don't know. I want to just tell you that right up front. I don't know. What we do is we treat people with other drugs that are like this one, and you can see they end in azole, and itraconazole, and then these more active drugs, voriconazole, posaconazole, isobuconazole. Those are all oral drugs. Some of them can be done intravenously as well, that really work for fungal infections. They've got other problems that we can talk about if you're interested, so that it's probably sensible to go back to itraconazole at some point, because it's a little bit easier in some ways. But these are the drugs that we use now as our breakthrough agents. And why is that a problem? Because for reasons that must be tied to the CGD genes, every boy with CGD seems to be desperate to be a lawnmower. Have you ever found this? I'm just blown away by it. I mean, every boy I knew growing up said, I mow the lawn. What are you, crazy? No. You tell a boy that the thing he's not supposed to do is play in dirt. The first thing he wants to do is, hog wrestle. So this is the absolutely typical CGD boy who decides, at age 12 that he's going to make his career in landscape architecture. And that's fine, but this is the only way. For those of you who remember Gilligan's Island, the way Mrs. Howell did the lawn, this is the way you should be doing the lawn if you have chronic granulomatous disease. So it's a problem, and it's a problem for exactly this reason. So this is not the patient I'm going to show you, but this is the risk. And I know of several young women, and it's mostly young women because they've got this milder form of CGD. They don't know they're at risk, and they go out and they mulch. And here this woman, is being very green and organic, and she's mulching, but in the process she gets a lungful of fungus. And that's really dangerous. It's very unique in chronic granulomatous disease. So this is a girl just like the one I showed you there, who 10 days after mulching, her lungs were completely covered. Now, it's important to know that, because once you, and you need to know it as a parent, suddenly your child says, gosh, I'm having fever and I can't catch my breath, and you need to stop and say, wait a minute, were you playing in that shed in Freddie's house that is full of mold? Were you helping somebody mulch? I mean, I don't make these stories up. These are the stories that I get, right? What were you doing? Because it's always their fault, right? What were you doing that got you at risk? Just keep that in mind. So these are things. It's hard sometimes to sort it out. So mulching is a big problem. In this woman, it required a lot of treatment with both fungal therapy and steroid therapy. But when you do it right, she got completely better and is now back to doing all the things that she's supposed to be doing in her mid-20s. And you want to keep this in mind, because it's a very standard way that people with chronic granulomatous disease can get sick. And you can see here in these x-rays, they're all the same, that they've got this very fluffy, bilateral, both sides, very fluffy sort of appearance that tells you that there's something wrong. So we talked enough about that. Okay, just for a minute. So what is interferon? So this is a topic, this causes a lot of discussion with all the patients. And I'm just going to be clear about what we think about it. So it's a perfectly natural chemical. It clearly stimulates cells to fight infection better. And we know that when it's missing, so if you have one of those diseases where the gene is missing, or where they can't respond to it, or they're neutralizing it somehow, when that happens, they get really sick. Not with CGD type infections. They get really sick with other stuff. But you know what? There's no problem with interferon in chronic granulomatous disease. There's not one iota difficulty that a CGD patient has making interferon or responding to it. And yet we still think that it's useful. And this is the reason why. And so maybe you can ask Dr. Jennery later, because in England, first off, they drink their beer warm, right? And second off, they don't think CGD is as much benefited by interferon. But here, we think that it's important. And this big study done in 1991 showed that if you took interferon versus if you were on a placebo, this is the number of people who did not have an infection. So 77% did not have an infection at the end of 1 year versus about 30%. That is, giving interferon prevented infections in chronic granulomatous disease in that randomized, prospective, double-blind, placebo-controlled trial. That's not quite as complicated as saying Abu Bakr, but it's getting close. But those are the data. That's the human data. But when you say, why does it work? I don't know. Nobody knows. And it's not like I haven't looked a lot. There are a lot of things it might do. We don't know exactly what it does. But what we do know is that it's like building up a levee around something, building up a wall. That's how I sort of explain it. You're talking about how much protection do you want? How much insurance are you ready to buy? So that just reminds me, we are in, New Orleans, yeah. So just reminds you that what is a levee? I always wondered about this. I thought it might be a religious group. No, what's a levee? This is a small wall that keeps the water on one side and the land on the other side. And you build it up to keep things in their proper place. And when the levee's not high enough, you got a problem. And you want to be thinking, is my wall high enough to prevent these things? And so this is how I sort of think about the use of interferon in chronic granulomatous, because I don't know how it works. This doesn't mean that you can't have the wall, if the water comes high enough, ain't no wall you're going to make that's going to be useful. That's just the way it is. But you're talking about how much do you want to do. So, Sergio talked, and I know Theo Heller's going to talk about the inflammatory and granulomatous complications. So there's inflammatory bowel disease, sometimes referred to also as CGD colitis. Lung scarring is a big deal. and we don't understand that very well. We don't understand how to treat it. Sergio showed you about wound separation or dehiscence. This is also very common. We don't understand exactly why any of those happen. We know that steroids seem to be very helpful in most of them, again, for reasons we don't really understand. And there are other drugs really coming close on the horizon that might be important. So finally, how to live with chronic granulomatous disease. You know, prevention is just not all about Purell. Part of the reason to remind you about what are the organisms that cause infection in CGD is that almost none of those are organisms that are carried on your hands. Almost none of those are ones that you're going to be getting from a doorknob. Almost none of those are ones that are going to be made a whole heck of a lot better by keeping the house spick and span. I'm not in favor of keeping the house the way I would keep it if my wife weren't here to tell me different. But I am saying that Purell isn't going to make the big difference in this. Those infections that people get are infections that are typically out in the environment. We don't really understand how to prevent most of them, except the fungi. Antibiotics, antifungals, interferon help. But, you know, a big anything will overcome a modest something. Some big exposure will not be prevented no matter what you do. If you take a big enough inhalation of mulch, you're going to be in trouble. It's very important that you help your doctor. It's very important that you help them know exactly what's going on with you. It's very important that for those of you who have doctors who don't know about CGD, or if you have to go to emergency rooms, educate them. They're not stupid. They want to help. But they sometimes need some of your assistance to know exactly what that help should look like. Finally, you as the patient, and not your mom, you need to know your medicines. Now, at what age does that take effect? You know, how long do you get a pass? I'd say about age 7. After that, you know, it's time to start taking ownership, because moms will do everything. We all know that. We all rely on that. But it's sort of not fair to them. And in the long run, moms are working very hard to make sure that sooner or later you get out of the house and have your own life. And if you don't figure out, I mean, despite what you might think, you know, and sooner or later you have to know what you're doing. You have to know how those medicines get arranged and how they get adjusted. So, you know, like I said, everybody's got their own zebra. All the different zebras do things a slightly different way. And our job is to make sure that you and your zebra get just as far as you want to get. Thank you very much.
So I'm grateful for the invitation. Although most people are not grateful after hearing me speak, I'm still grateful for the invitation. And my topic was CGD in the gut, CGD and bowel disease. So I'm not going to really address liver disease at all. And the first thing to say, and I'm going to make this a theme through the talk, is that the bowel disease we see in CGD is inflammatory bowel disease, but it's not Crohn's and it's not ulcerative colitis. It's a different entity. So I have several biases, gastroenterology and coffee being the two main ones. And I was hesitating whether to put gastroenterology up there, and I'm not a pediatrician. And there are a number of reasons for that. I'm scared of the parents. And also, children ask too many honest questions. So I walked into, and I'll tell you why I'm hesitating to say gastroenterology. I walked into a patient's room last week, and the patient's mother said to the child, it was about 10, "This is a gastroenterologist." And the child said, "What does he do?" "Well, he's here to talk to you about colonoscopy." "What's that?" So she started to explain to him. And then he looked at me and he said, "How big is that tube?" And I said, "It's about 6 feet." I should have kept my mouth shut. So then he said, "Do they pay you for this?" I said, "Yes, tax dollars." And then it got worse because he asked me if I enjoy my job. So how do you answer that? Either way you lose, right? If you enjoy it, you're bad. And if you don't, well, then I don't want you to see me. So I have no real biases. I try and see everything equally. I like zebras a lot. I spend my life looking at zebras, and I don't want to see the horses. I'm far more interested in the zebras. I think they're deserving of attention. And I have no conflicts other than that. But I am your tax dollars, as I said. So what I want to try and do, and Sergio told me I have 40 minutes, Steve told me I have 20 minutes, so I split the difference. I'm going to speak for 60 minutes. And I'm going to try and understand how CGD affects the gut, and I'm going to talk to you about that. And it's a very conceptual and clinical approach. Despite Sergio asking me to be molecular, I'm going to stick to the clinical. This is where I live. This is my home. It's where the rest of us live as well. It's the NIH Clinical Center, and this is the hospital. My room is somewhere here, Dr. Holland here. Sergio's in the basement. But that's where we live. And in case you're wondering about federal employees and whether we work a full day, I took this picture of a sunset to show you that some days I do stay there late. It was in the winter, but Bethesda can be beautiful too, not just New Orleans. So let's go through some basics. And again, feel free to interrupt. What Sergio said, you can ask your questions during the talk, and if there's things you want to know about, stop me. So we should talk about what the gut does, right? We should just revise that. It's essential for life. The first thing that we all think about, Dr. Holland said, he's thinking about dinner, not the lottery, right? Pleasure of eating. But we need it for energy and nutrients. It's really important. You asked the question about growth hormone, inflammatory bowel disease. That's really a big deal. That sort of inflammation and malabsorption and damage to the gut really affects growth. The gut's also really important in immune regulation. So I'm not saying that the people with bowel disease have different types of infections, but it really is very important for all sorts of things related to the immune system. And the other thing the gut's responsible for is quiet time. It's an excuse to get some quiet time behind a closed door. I just want to stop. This is really very beautiful. I just want to pause here and appreciate the beauty that the gut is. And let's just go through it for a second. So esophagus, food spends about 30 seconds in the esophagus. Right. Once you've chewed it, it goes through. Stomach, 90 minutes. Maybe if you ate cabbage, 3-4 hours. But very fast. And then the small intestine, anyone guess? Sorry? No, 3 to 4 hours. Some people longer, but 3 to 4 hours. How much small intestine? We have 11 to 32 feet. It's very long. There are very few bacteria all along here. Very few bacteria. It's relatively sterile. Then we get to the colon. That's a different story. Not sterile at all. But we're meant to have bacteria in the colon. They're essential to health. And there's more and more evidence that this is really a crucial part of being a healthy person, having a diverse group of bacteria inside your colon. And if you think about it, we're designed that way. There's a reason the appendix is hanging off the end of the colon here where the small bowel comes in. It's to keep the bacteria from getting into the small intestine. And there's a lot of immune tissue here. It's to keep the bacteria out of the small intestine, like the tonsils do here with the mouth. So we were meant to have no bacteria in our colon. Our appendix would be hanging out our butts. It's not, right? It's here. So the colon is about 5 to 6 feet long, full of bacteria. How long does food spend in the colon? 36 to 72 hours. Very long. Right? So we said we eat to absorb the food, right, and the energy, but that happens here. So what's happening over here? Why are we keeping the food in the colon for so long? It would be easy to make a small pouch, keep it in the colon for an hour or two, store it until you can get to a bathroom, and then poop it out. Right? Why does it have to be there for so long? It's because we're feeding those bacteria. It's because we depend on those bacteria. It's in there for a reason. Those bacteria are extracting nutrients. They control growth and energy metabolism. They give us things like folate, vitamins, micronutrients. They're really important. But what's the problem if you have an immune system that's not perfect? This is full of bacteria. If your immune system's not great, that may not be a good thing. So what's really interesting is that now we think of all inflammatory bowel disease as being kind of an immune defect. And we think of all inflammatory bowel disease as being difficulty in either sensing the bacteria or handling the bacteria. So we stop for a second. So if I can see my son coming and he's got that look on his face, I can head him off before he gets to my wife. I can prevent the explosion, right? She doesn't need to know what he just broke. But if there's difficulty sensing and he gets through, there's an explosion. Not my wife. My wife's wonderful. But let's say a different wife. If she was overreactive, or if I was overreactive, there would be a different problem. There would be handling, inability to cope or handle. So sensing or handling the bacteria turns out to be a problem in all inflammatory bowel disease. And I'm just going to say this here because it's really interesting. The severity of the CGD doesn't seem to be related to whether you get inflammatory bowel disease or not in CGD. So that's also interesting. We can come back to that. Any questions? Okay. So for this system to work, there are a couple of things that are really important. First of all, you need to get food. If you don't put food in it, it doesn't work, right? And so the reason we have a brain and the reason we have arms and legs is to feed our gut. No other reason. Once it gets in there, it's got to move through. We spoke about how long it spends in different places, and it's got to keep moving. It's got to keep moving, otherwise it won't get to the next place. You've got to digest the food, that means break it down. You've got to absorb it, get it into the system, and then you've got to eliminate waste. So these are the essential functions, and we're going to sort of see how that ties in to CGD. Oops. So what can go wrong? Well, please don't tell anyone I said this in public, and this is where you should not record, but the gut is kind of dumb. It can only react in certain ways. It's got limited responses. So you guys, very sophisticated, you can come back with a clever answer to whatever insult you're given. The gut can't do that. The gut usually has very few options. Mostly pain. If it's in the upper intestine, there's nausea and vomiting. If it's in the lower intestine, there's diarrhea and constipation. And anywhere along the way, if there's a problem, you can get bleeding. That's it. Not very complicated. So easy to understand. So we use those symptoms, and we use the way the patient tells you about the symptoms to understand where the problem is. So if someone tells you, I'm having 15 or 20 bowel movements a day, that's only the colon. Can be nowhere else. They say I'm having 1 or 2 very large watery diarrheal stools a day, mostly small bowel, not always. So we can use the clues. That's why we ask you all those questions. First of all, I like poop, and I like talking about poop, which is why I ask you the questions. But the other reason I ask you about the questions is because it tells me where I'm going to put that tube. And it tells me what to look for and where I'm going to look. Does that make sense? So it's not just, let me ask you about your poop. An amazing 40% of CGD patients in our cohort at NIH, again, get inflammatory bowel disease. Some form or another. And it goes from very mild to severe. Very severe is rare, but some sort of spectrum of the inflammatory bowel disease, 40%. That's a lot. So this is common in CGD. What about, so now we're talking about CGD, not in general. The commonest things we see are diarrhea. Inflammatory markers go up. Dr. Holland mentioned the ESR and the CRP. Those are blood tests for inflammation. We often see anemia, and with anemia we often see growth retardation, which you asked about. And what's really interesting is you almost never see patients complain of significant pain. So that's very different to Crohn's. Every Crohn's patient knows and loves narcotics. Every ulcerative colitis patient has a hotline, speed dial to get their narcotics on refill to the pharmacy. CGD, we don't see pain at all. It's very unusual. There are some patients, but it's not typical. So that's interesting, I think. Very different. And just to go through the things that we see in CGD, and I divide it into 2 groups. The first is related to movement, and the second related to inflammation. So in CGD, problems related to movement, okay, the way things move through the bowel. Remember, it has to move through to function. So the first problem is some people have swallowing difficulty. And the food gets stuck and doesn't go down. They have to wash it down. And that can be because the muscle doesn't move or because they develop narrowings or strictures. But mostly because the muscle doesn't move properly. They can develop nausea and vomiting. because of the outlet obstruction, like Sergio showed you, but also because the stomach muscle doesn't work. The stomach becomes floppy, sits there, says, I'm sick of this. I'm not going to work today. And it doesn't contract like it should. So the food sits there, you feel nauseous, you feel full, you vomit. Not common, but it does happen. And constipation. Constipation is a big thing. So let's say you're going to have a bowel movement once a week. Not good, right? But let's say that was the case, because you have CGD and your colon doesn't really squeeze like it should. But you add inflammatory bowel disease to that, and instead you have a bowel movement every day. So you're very happy. You say, I don't have diarrhea, I don't have constipation. But that fools me, because I think you're normal, but meanwhile you're having more bowel movements, 7 times more bowel movements than you would have had, because constipation is such a feature, even inflammatory bowel disease in CGD. So for us, as gastroenterologists, one of the most confusing things when I started seeing patients with CGD was the lack of real diarrhea. We do see it, but not as commonly as you would expect. Inflammation presents in a number of ways. Ulcers, and I'm going to show you some nice pictures, or I think they're nice. I hope none of you recognize yourselves. Fistulae, which is a connection, like Sergio showed you, between two things that shouldn't be connected. And I'm going to show you a picture of that. Abscess formation, I'm going to show you something that's a collection of pus in the liver. I'm going to show you somewhere else. And strictures are, as a result of inflammation, people get narrowing. Okay? So these are the cardinal features of bowel disease in CGD. So this is the esophagus in a patient. And I don't know if it projects well. The lights are. So the esophagus is a beautiful tube. It's straight, smooth. It's got this pearly sort of translucence to it. It's very pretty. And you can see this is a normal-looking esophagus, except for these ulcers. These are ulcers going down the esophagus in lines, in rows, marching down. And this white on the ulcer is pus. And this is not an infection. This responds to anti-inflammatory treatment. So you can see disease in the esophagus, but not so common. This is another, just to go back to the movement. When the esophagus contracts, it's beautiful. It's like a wave. When you're sitting in there with an endoscope and you watch, you see the wave move through. In CGD, you don't often see that. And what you can see here is that the rings, do you see these sort of rings going down? Do you all see the rings? Okay. These are little parts of the esophagus just contracting at the same time. How's food going to get through if everything's just squeezing at the same time? The other thing that's abnormal, it's not a nice circle. Do you see sort of a funny shape? And it can even look like a keyhole. So the movement and the muscle often isn't normal either. The stomach often isn't, in about 75% of people who've got colonic involvement, we see stomach involvement, but it's very mild in terms of the inflammatory bowel disease type picture. And what we typically see is a small linear ulcer like that. You see the raised area here? And over there in the middle, there's a little cleft ulcer. What's also interesting is, do you see the stippling? Normally you don't see the stippling, but that's because the stomach is edematous or swollen. And so all the pits in the stomach become pronounced and easy to see. Now we get to my favorite organ, the colon. Well, second favorite, actually the liver, but for the moment. So this is a pretty nice looking colon, good looking, pretty beautiful. You see the vessels coming through. This is bits of bile and mucus. That's normal. But you see these little white ulcers? They're like cold sores. This is the first stage of colitis. This is what we see most often in people with very mild or early disease. Little abscess ulcers. Those patients often don't have symptoms, but they might be anemic. They might have growth retardation. And they might have elevated inflammatory markers. Usually they don't have GI symptoms. So you have to suspect it to look for it. And I'm going to walk you down the ladder of severity. And when people see this, and I tell them they're mild, they say, why should we be treated? When I see this, I say, it's early yet. And what we're trying to prevent is where we're going, where I'm going to take you. So this is a little bit more advanced. So do you see the vessels are dilated? Before we saw a few vessels, now there are lots of them. It's because it's inflamed. The vessels are all dilated, bringing those immune cells which I know nothing about, into the territory. See the ulcers, this redness, this patchy redness? There aren't any real ulcers, but there's lots of patchy redness, and the abscess ulcers, and the vessels are all excited, and the mucus is different. The mucus is more sticky, right? Not as smooth. It's dried out. So you look in that, you say, oh, this is someone who's progressing. Then it goes to the next stage. So you see this is the ulcer here, and it's surrounded by redness and swelling. And if you look at, you can't really, you have to take my word for it, but there's no nice vessels in the rest of it. Now the vessels are going away. This is a longer-term disease. And this is where patients can end up. All of this yellow here is an ulcer. Do you see this? Right? This is one huge ulcer. And this area around it, this is red and inflamed. There are no vessels. It's swollen. The lining is stripped off. This is more severe. These patients have diarrhea. And these ulcers are very deep. This is what Crohn's disease looks like, which is why people often think CGD, inflammatory bowel disease, is Crohn's disease. But it's not. I'm going to tell you why. So any questions so far? No? Okay, and I just wanted to show one picture because I think it's very telling. This is a granuloma, sort of the edge of it. But all these blue dots are inflammatory cells. This is the colon. And the colon is normally very neat and ordered. It's very meticulous. You don't think of it as being meticulous? I'm sure you don't. You think of it as being poopy. But it's not. It's very, very structured and symmetrical. And there are these beautiful rows of glands. They make the mucus and all sorts of other things. You can see this guy used to be one of these. And you can see these guys here are being destroyed by the inflammation. And this guy's about to be sloughed off. Here's a little bit of the lining that's left. But the lining, the nice, normal, smooth lining is completely gone. So we take biopsies because the biopsies are helpful for us. They allow us to assess the severity in a different way. Because if you look at this patient, that biopsy that I just showed you might have come from here. So it again gives you a sense of the severity. Okay, what about abscess? I'm going to show you just one picture. Oh, I'm sorry, it doesn't project. You have to take my word for it. This is a man. Let me see. Okay. Thank you. So this is a man lying on his back. Here's one hip. Here's another hip. This is an MRI. Here's the base of his prostate. Here's his rectum. And you see there's this white thing here filled with fluid and air that sort of snuck into a particularly private spot right next to the prostate. Should not be there. That's a collection of pus. Right, so abscesses form not just in the liver, but in this area around the rectum and anus, in the buttocks, next to the prostate, next to the bladder, around the uterus and vagina, very commonly. No, it's rare. So don't get worried. What about fistulae? So this is another MRI. Here's the liver coming down. This is the stomach. Here's the colon. There's a little bit of small bowel. And you see there's this abnormal connection between the colon and the stomach. How do you think that guy's breath smelled? The colon is high pressure area because the gas. Stomach is used to collapsing. The gas goes this way to the stomach. Burping wasn't a pleasurable experience for him. So that's a fistula. That's an example of a fistula. Also rare, fortunately, but we in a tertiary center, Dr. Holland has a way of finding them, and like he dragged me into pediatrics, he drags these patients in. What about the anus? And this is a particularly instructive case. Here is a very ulcerated anus, and if you can imagine, this was a flap of tissue that you could do this to. So she actually was a gymnast and hadn't really told anyone about this. We treated her and she healed very beautifully. This is normal anus, in case you're wondering. And then she developed a complication in the treatment, which I'm going to come back to. So we had to stop the medicines. Look what happened when we stopped the medicines. And this is a better picture, and you can get a sense of the flap. Those are my fingers. Nice fingers, right? And it looks terrible. But again, with treatment, she cleared up, and she actually had a bone marrow transplant and has done fantastically well. And one of the important things about bone marrow transplant is that the bowel disease generally goes away. So that's also rare, in case you're worrying. Let's talk about location for a minute. So why it's like Crohn's is because they get these ulcers. Patients get ulcers that skip and have so-called normal-looking areas in between. But why it's not like Crohn's is that if there's disease, the rectum is almost always involved, 90%. And in fact, those people we've done, this is our endoscopy at the NIH, about 150 endoscopies. In my experience, in those patients where the rectum is not involved, they're already on treatment. When we get patients who haven't been treated, the rectum's always involved. So this is the progression. If this is involved, the end of the small bowel, for sure the rest is involved. It always, you can have rectal disease only, but if you've got disease on the other side, remember my initial beautiful picture? If you've got disease on the other side, for sure you have rectal disease. So like ulcerative colitis, it starts on this end of the bowel, in the rectum, and it moves across. It doesn't really move, but in terms of how we think about it. So the distribution is like ulcerative colitis, but the ulcers and the way they look is more like Crohn's. Does this figure make sense? Okay. So let's talk about treatment. And I'm keeping this very simple, and I did not mention bone marrow transplant because I know it's going to be addressed. We use medicines, and we approach it in a stepwise way. We want to define, when we get a new patient, the first question we ask is, what part of the bowel is involved? Because if it's just the anus and rectum, we don't have to give you toxic medicines to swallow. We can just give you suppositories or enemas, and we don't have to get the side effects. If it's involving the whole bowel, or most of the bowel, upper bowel too, then we have to give you systemic therapy. If it's mild, we don't have to give you very toxic medicines. Even if it involves the whole bowel, we can start with medicines that are less toxic. But if it's severe throughout, we have to go to the more toxic medicines. So what I'm saying is we try to be appropriate for the geography, for where the disease is, and for the severity of the disease. So patients come in and they say, where are you going to put that 6-foot thing? And like all of you are clenching right now, that's what they're doing, and they're moving to the other end of the bed. That's why we do it, because we don't want to give you medicines you don't need, and we don't want to give you toxicities that you don't need. We want to be sure that you need that medicine. So we want to understand where the disease is and how bad it is. And remember, the disease involves immunosuppression. So if you get too exuberant, and if you get intoxicated by your own exuberance, and you give medicines that are too immunosuppressive, patients will get infections. And we've had experience with that where we've done damage to patients by immunosuppressing them too much. The patient I showed you with the anus, we gave her pneumonia that put her in the intensive care unit. We fixed her anus, but we nearly killed her. Right? I'd rather have an anus that's not well. So we've learned lessons along the way, thanks to patients coming to us and humbling us and teaching us how often we're wrong. And I think now we understand sort of the levels, that how far we can push and how far we cannot push. But that doesn't mean we can always fix things. And sometimes we're stuck. And then we go to surgery. If not bone marrow transplant, we go to surgery. And surgery is very useful because you can divert the stool away from the colon. You can bring the small bowel out here, and people wear a bag. It's called an ostomy. And the bowel disease gets much better, but doesn't go away. You can drain the abscesses like the one I showed you. And if all else fails, you can actually cut out the whole colon. It's called a complete proctocolectomy. And you can also do what's called an APR, abdominoperineal resection, where you remove the anus as well. And we have a couple of patients who've gone to that. And 2 weeks ago, I saw one of the patients who I hadn't seen since 2006. I'd seen him almost every month. The last time I saw him was 2006 after that surgery. And he said to me he doesn't know why he resisted that surgery for so long. His life has been normal for the first time in the last 10 years. So when we talk about surgeries like that, parents and people often look at us and say, whoa. But sometimes, at the moment, given our current therapies and our current limitations, that's what we're stuck with, and we would never recommend that lightly. But again, that's rare. Okay, so the future. Cure is beyond the scope of what I do. I just like to play with toys. And we can learn from other inflammatory bowel diseases. We can learn a lot from other inflammatory bowel diseases and how they're treated. And we've tried very hard to keep track as the field has progressed. There's more risk in CGD, as we've said. People are already immunosuppressed, and we're adding to that immunosuppression. There are unique approaches that we can take in CGD, and I think it's a wonderful time to be a mouse. We can cure so much in a mouse. We give them the disease, we cure the disease, but actually I don't care about mice. I care about people, and I care about the patients, and I want to see those therapies come to humans, and I want to see them work in humans. And that's hopefully where we're heading. And we should use the mouse as models, and I don't mean in Playboy, I mean of the disease. And we should use targeted approaches. And an example of that, something that I don't know is going to work, but has become very significant in ulcerative colitis, is a drug that targets cells that respond to bacteria only in the gut. Right? So how does an inflammatory cell know to go to the gut and not to the nose? Right? How did the lymphocyte, the neutrophils sitting in my gut now, know that it should go to my gut and not to my nose, or my sinus, or my ear? Because they're flags, they're signals. They're called integrins that tell the bacteria, that tell the cells to go to the gut. And we're developing an understanding of those integrins, and we're developing ways to block them. So I want to thank the patients, and if only for the opportunity to thank patients for teaching me and humbling me, I'm grateful to be here speaking to you. I want to thank my fellows, my trainees who've worked with me over the past 2 years with the CGD patients. They're listed here, the pathologist and the surgeon, Dr. Casado and Dr. Hughes. And I especially want to thank the real deal. And that's the CGD team at the NIH, the people that I've worked with. I didn't put Vicky's name up there because Vicky I haven't really been torturing Vicky recently, but Vicky was very much part of the initial trouble. But everyone else I think that I've tormented is up there. And also Sergio's not there because he's in the basement. But I particularly want to thank Dr. Holland for dragging me into this, kicking and screaming. I'm so grateful. It's been so rewarding and so exciting. And the opportunity to learn and grow and stretch and make a difference in people's lives is, as MasterCard says, priceless. I wanted to end with, I showed you a sunset picture to start. I wanted to end with a picture of the dawn. And because I think it's a new dawn. This is my youngest son. He woke up, and this is a place we go to on vacation. He woke up very early in the morning. You can see it's dawn, just breaking, and he went to fish. And he caught this tiny, tiny fish. Do you see it? I don't know if you can even see it. And he was so excited. He screamed, and he woke the whole neighborhood up. And I think if there were any frogs sleeping, he woke them up too. And the point is, we're just catching small fish. We're just at the beginning, right? This is the dawn of a different era. And as Dr. Holland showed you the progress, I'm hoping that we make the same progress and continue to make that progress with CGD GI disease. Thank you.